We know about CT that it's the best test to rule out coronary artery disease, and we know that the methods we have for identifying those patients going to the cath lab are not very accurate. The same for CT. Maybe it's associated, or it seems that it's associated with improved outcomes compared to conventional examinations, but it seems that it increases the downstream utilization of cath. So we have a problem with CT with regard to ruling the disease, right? So in my institution, 3 years ago, we implemented FFR-CT that had showed promising results with regard to reducing the number of caths. So we implemented that as an additional test in patient having a positive coronary CT examination. So the rationale of the study was to assess outcomes. We know that it can reduce the number of caths, but we didn't know whether this strategy was safe or not. So this was the rationale about the study. The purpose of the study to assess safety of this strategy, CT plus, FFR-CT in patients with moderate coronary artery disease. This is a real-world study, so it's a poor design. It's a observational study, real-world data, one-center study. We divided patients into those having a perfect normal CT. We used this as a control group because we know that these patients have an excellent prognosis. So that was kind of the internal control group. And then with regard to FFR-CT, we divided according to whether the patients had a positive, that means a value of FFR-CT below 0.80, or a negative FFR-CT study. And the primary aim of the study was to assess safety in the 2/3 of the patients who had a normal FFR-CT result. And we want to compare this with the internal control group, those having a normal CT result. So we had about 2,500 patients with a normal CT result, and we had 450 patients with a normal FFR-CT result. We wanted to compare the outcomes in these two arms. And then we had the positive arms. That was secondary. And what happened there? We divided those with a positive FFR-CT result into those who we sent to the cath lab and those who we managed with optimal medical treatment alone. The findings was, and I think the important message here is that we could reclassify patients' risk, those with a negative FFR-CT. 75% of these patients had a stenosis more than 50%, and we ended up in this cohort with a group of patients that had the exact same prognosis as those with a normal CT result, whom we know have an excellent prognosis. So that was the main finding of the study, that patients with a normal FFR-CT, although they have coronary artery disease, have an excellent prognosis over 3 years follow-up, up to 3 years follow-up. That was a major finding. On the other hand, patients with a positive FFR-CT result, those who we sent to cath, where revascularization was a possibility, they also had a good prognosis. However, those with a positive FFR-CT result, who we did not, for some reason, send to the cath lab, they had a very poor prognosis because they had a 6-fold increase of myocardial infarction when compared to the other FFR-CT positive groups who we sent to the cath lab. So we still have a lot to learn, right? We know a normal FFR-CT result in patients with a moderate severity of coronary artery disease, these patients do good. But in patients with a positive FFR-CT result, we still have a lot to learn. How should we interpret a positive result, and how should we manage these patients best? Should we really send all to the cath lab? I don't think so. We still have a lot to learn. So this was just the first study assessing outcomes, intermediate term outcomes in patients having FFR-CT performed in real-world practice. Negative result, you do good. This was not a randomized control study. This was purely observational. And it was in one center. So we somehow have to confirm these registries. We cannot say that what we found you will find in another institution, right? So we need more data in prospective and multi-center fashion, right? And right now we have the advanced registry running, more than 5,000 patients having FFR-CT performed in a real-world practice, and we will have the first outcome data within the next 6 months, up to 1 year. And we'll follow these patients, and we'll see if we can mirror what we found in this registry trial. And of course, it would be nice to have randomized trials with FFR-CT versus conventional ischemia testing in patients with coronary disease with CT, randomized patients to conventional testing versus FFR-CT. And these studies are in pipeline also. This was just the first step.